Right. Hello, everyone. This is Suman Mishra. I'm part of GS Lab Gavs, and very excited to welcome you all to this presentation, which are going to be more of an interactive session with Dr. Nick Patel on value-based care and data management. So thank you, and people are starting to join in, as I can see. We'll probably keep going as the count goes up. So Ashura, can you go to the next slide? I just want to quickly introduce myself. So I'm Suman Mishra. Like I said, I'm a CTO for healthcare. Have been in healthcare industry for 15 years. I was part of Kaiser Permanente before joining GS Lab and Gavs. My primary focus areas have been on digital innovations and cloud, specifically using AI to build healthcare solutions that go deep into patient care and behavioral health and social and clinical setting. Condition management has one of my primary focus areas when I was in Kaiser. But as we go into technology solutions and other chat GPT and every single technology solutions evolve around us, how does it impact our total health outcome is my primary focus these days. So I'm privileged to be part of this conversation. It's going to be a very interesting conversation today, which in a way, it's a learning session for all of us that are part of this call. And I'm extremely privileged and honored to introduce Dr. Nick Patel, who's the founder and CEO of Stealth Consulting. He has been with Prisma Health for a long time as the Chief Digital Officer. He has been in practice as a hospitalist and a primary care physician for 20 plus years. So, it does gives him a lot of credibility into what he talks about, value-based care in general, but also how can that be implemented in a provider or payer setting or even an integrated care setting. It makes him as a unique speaker. So like I said, I'm very honored to have this conversation with Dr. Patel. Dr. Patel, do you want to add anything to what I just said before we begin the conversation today?
No, great to be here, Suman. The value-based care is such an important conversation, not only happening in the United States, but worldwide, and I look forward to our conversation.
Great. All right, going to the next slide, and we'll make it more conversational, but we want to show some slides to make sure people understand the context and have a visual in their mind as we talk through these topics. So today's agenda is going to be multifaceted, two-faceted. One is understanding the value-based care, how critical it is, what are the key enablers, and what are the current state that every state is operating on. And then we'll jump into a little bit, talk about data management and how data management is a key to implementing value-based care the right way. And what are the elements that we should be aware of and should watch out for, and things like how to build the right kind of architecture to support value-based care, which has become a standard as we go into the 2023 plus. So without further ado, if we can go and start engaging with the audience. I'm looking at the numbers, it's more than 70 people now on this call. So let's have a poll about a very simple but more important thing is, if you can go to the next one. Yeah, how familiar are you with the value-based care, right? And if you can choose your answers, it's very simple answers, but be honest about it, and then let's see where we stand. And this will give us more understanding of the audience and how we are kind of positioned. So take roughly about 30 seconds to record your response, please. Okay, a few more seconds. Okay, let's look at the results. Dr. Patel, do you see anything unique, unfamiliar? How do you read this?
Yeah, I mean, it says 29% are not familiar. So that's a third, right? Almost a third. And somewhat familiar, you got 58%, and very familiar, 13%. So that's the minority out of 52 folks who took the poll. I'm not too surprised at these findings. It's value-based care has been discussed for over multiple decades now. But before we start actually going into defining what value-based care is and how the government defines it, how payers define it, one thing I like to always start off with is that understanding of actually how we make a dollar in healthcare, and as I call it, the anatomy of a healthcare dollar. So, as most of you know, 70% of health systems, nonprofit health systems, are underwater when it comes to margins this year. And the stresses of supply chain and staffing cost have really put a lot of strain on health systems. So, if you look at this dollar, it kind of makes sense why. Because the margin that most health systems are dealing with are 2 to 2.5%. And that's about the national average. Now, there obviously are some health systems that are doing much better than this, but most of them on average fall within that very narrow margin of 2.5. So let's start with what cost health systems, right? We talked about staffing. Now, that has been a huge cost for health systems during the COVID pandemic. A lot of nursing shortages, a lot of locums doctors coming in, both as hospitalists in my organization. We had so many locum providers coming in, and you're paying almost 2 to 3x the salary when you bring a locums provider in compared to an employed provider. All right, and the same thing happens with nurses, and it caused a lot of strife, right? You had nurses who were making a certain salary, yet they're seeing people next to them who are making 2 to 3 times their salary, yet doing even a lesser job sometimes, because the traveling nurses do not know the health system as well and how everything functions as well as an established provider or nurse. And so sometimes even the employed nurses and providers are taking up slack for those who are traveling. We still needed them. They provided great care, but it caused a major issue in most health systems around what is fair market value for your providers and how are you paying for them? And what's how are you going to make sure that you're not giving unfair payment to one group versus another? So staffing still is gotten better. We don't have as many traveling providers and nurses at most health systems, but they're still present. The other thing is supply chain, right? Cost of everything, as we all know, when we go grocery shopping, inflation has hit everybody. And that includes everything down to a bandage, to drapes, to sheets, to everything it takes to take care of a patient. Those costs have gone up as well. So again, that hits your margin. When you look at ambulatory practices, right, what I found as vice chair of medicine is that in order for a practice to have even just break even in primary care, you need to at least have 4 to 5 high producing providers in that office in order for you to even break even. If you have onesie, twosie providers and practices, most likely they're not going to be able to generate enough revenue to overcome the overhead in that practice. So the overhead costs is on the space, the brick and mortar location, real estate has gone up as well. And so that also, again, affects the margin. The other piece is no-shows, right? When someone has someone scheduled for a procedure, especially, and they no-show, that costs health systems money because they don't typically overbook or triple book procedures. We saw this happen with colonoscopies. Again, this is where technology can help play a part, and appointment reminders and education, and for colonoscopy, making sure they picked up their prep and they're ready to go, and the reminders are done, T-minus 24 hours to the appointment. And hence that can help with the no-show rate. And then on top of all of this, with economic inflation and everything else, reimbursements are changing. And we're going to talk about that here in value-based care and how that affects everybody. But at the same time, what you used to do in the 80s and 70s per volume, per patient, is drastically different today. Now, let's look at the other side. It's how do we make money, right? One, it's volume-based. The number of procedures, especially elective surgeries, hips, Any sort of procedures are going to have a higher margin. Chronic care management is another one. There's codes that you could do for management, which actually also helps with value-based care. We'll talk about ACC coding, annual wellness visits, quality care gap closures, but we still live in a very predominant fee-for-service world, right? So if a provider is seeing 18 to 20 patients, that's how they generate the actual the dollar within that practice. Coding is very important, making sure you're coding appropriately for what you're doing. And the good news is a lot of things now are going to time-based coding. So you may have a complicated patient and you may only talk about one problem, but that one problem took you 30 minutes, right? And so there's also a lot of time spent by provider in pre-reading what's going on with the patient before they get there. And right, and some of that time can also be documented. The other thing is hospital-acquired infection, HCAHPS scores, if done right, if those hospital-acquired infections and your overall ratings by your provider, your patients are good, then you're going to make a higher dollar amount as well. It goes into a factor as part of your overall reimbursement equation. And then there's shared risk, and we'll talk about a lot of shared risk. It's part of value-based care here today. So overall, this is in general how health systems lose and make money, and how those levers have to kind of play a part in making sure that you are able to keep the lights on in your organization.
Yeah, and
Next
Dr.
slide.
Patel, on this
Yeah.
one, if I could ask you a question on procedures. How do elective procedures act in this case? When COVID hit us, elective procedures must be like completely off from what was scheduled to be. Was that a key factor in this process? Like,
Yeah,
how did
it's interesting. Yeah, absolutely. So obviously emergent procedures, open heart, all those types of things, neurosurgical, those were done during COVID under safety protocols, but elective surgeries were pushed off and alternative measures were used. And if you look at the amount of income that payers made during COVID, they made a lot of money because they weren't having to pay out these premiums, right? They weren't paying for these procedures. They were pushed off. And sometimes they got better without needing a procedure, right? So physical therapy, alternative joint injections, those types of things were used in place and outpatient versus inpatient care for those procedures. And I think we can learn a lot from that. And so before we just go straight to a procedure, what are the other things we should be doing to stave off surgery unless absolutely necessary, right? But yes, absolutely, elective procedures were at an all-time low during the pandemic. I think we want to move to the next slide. So let's define value-based care. And like I said, about if you add it up, 70% of you kind of know it, and some of you maybe just heard the term, but have seen various definitions of it. But in general, I mean, there's the definition actually, if you look it up, is a long one. But here's the main portions of it. Value-based care is healthcare delivery model that focuses on improving outcomes while controlling cost and holding providers more accountable. Now, most people, when I first heard about value-based care, just in passing, I was like, well, isn't all care need to be valued and be value-based and quality-based? Well, unfortunately, fee-for-service isn't. In its core, it's all about volume. So value-based care adds this fact that say, hey, you're taking care of a diabetic, and if you're seeing this diabetic 4 times a year, their A1C score should be X. It should be better than 8 or 9 or 10, right? It should be under 7. And if you are doing that, then there's additional incentives, because one of the things that payers do realize that, and I as a practicing doc realized very quickly, is you get 15 to 20 minutes, if you're lucky, of FaceTime with a provider 3 times, maybe 4 times a year for certain chronic disease. That is not where all care happens. That's where some management and guidance and education and med changes occur. But what happens to patients with chronic disease around diabetes and hypertension happens outside your office. It happens at home. It happens in the environment. So in order for value-based care to be successful, we have to also understand that this is all about longitudinal care. This is about care that is happening at home where they live, in their environment, and understanding what are the stressors and social determinants that play a factor in making a person not get to their goals. I fundamentally, as a provider, believe that nobody wants to be sick. Nobody wants to have uncontrolled sugars and high blood pressures in order for them to get a amputation, a stroke, or a heart attack. Nobody wants that. And so what we have to do is be able to enable our patients with this accountability and this focus on quality to be able to take care of patients where they are, right? So why are we doing this now? Well, we're failing at delivering healthcare, and especially in the United States. The United States spends more of its percentage of its GDP on healthcare than any other industrialized nation. But with all of that, we're not getting any results, right? The A1C scores, blood pressure scores, wellness, exercise, behavioral health, all those things have better outcomes than other nations, right? If you look at Netherlands, you look at UK and some other European nations, they're doing much better with some of this. And so we have to start to think differently, because fee-for-service clearly doesn't work. And so why value-based? It improves patient outcomes. It hopefully contains cost. It promotes more population health, which is what we should be doing. It aligns incentives, meaning how does a provider get paid based on how does a health system get paid? What does the patient pay for? And what do they expect for what they pay for their premium? And what does the payer need to expect out of this, right? Enables continuous quality improvement. One thing you know about healthcare, it doesn't end at the end of your visit. It is continued improvement, and that means not only care that happens with the provider, but your care coordinator, your social worker, your pharmacist, your local folks in the community. Care is not just a provider-based initiative. It needs to be community-based, and it needs to have other parts of your care team take part in that person's care. And at the same time, what we're trying to do, we're going to try to drive payment reform. What is fair market value for a provider? When you bring a provider in, right now, the equation is pretty simple. I want you to see 18, 20 patients a day. This is what your salary is, and this is how much bonus you're going to get if you see more people. That's how it's pretty much based, right? But there's nothing to say if Nick Patel saw a bunch of patients and they all did. They didn't like end up in a hospital. There was no malpractice, but let's just say they never got to their A1C goal. They never got to their blood pressure goal. Should I still get paid exactly the same way versus a doctor who is actually taking the same volume, but taking better care of them? What is the incentives of actually that output? So the key enablers here is part of it has going to have to be strong government involvement in change. I know this is happening in nationalized health systems like in Europe and UK. India is going through this. The GAVS team sent me an article today, which I'm in the middle of reading, around how India is moving forward with more value-based care. And the other piece, and we're going to talk about this, and is focus on information technology improvement. It is so important to have clean data. And if you have inaccurate data, you're going to get dinged not only on what quality measures you're measuring, but what you get reimbursed for. So we're going to talk deeply about that. And instituting a value-based culture among providers. This is a tough one, right? This is not, I buy a solution and here, fix it. Culture has to grow from within. And you have to make sure that you are incentivizing and building that sort of culture within your organization of how we're going to move towards a value-based care world. And then the other thing is starting to adapt this time-driven, activity-based model. And I think that's really important too, because right now, when it comes to just fee-for-service, you're locked into about 15 minutes. But if you start to look at this approach, the actual cost of delivering care to a patient with a certain condition, for example, diabetes, are measured from the bottom up by looking into what happens to a patient in the course of a treatment and what are the specific costs of all the processes associated for the life cycle of that particular chronic disease. So it's not just episodic care, for example. Any comments on this, Suman, or anything that that strikes you as a major challenge or concern as part of this?
I think what you're raising is very, very important points, right? As healthcare transitions from fee-for-service model to value-based care, which I think should have happened 10 years ago, in my opinion, hasn't happened yet. But what you're trying to talk about is incentives and penalty. It's a carrot and a stick concept, which
Mhm.
seems very logical, very simple. But what you talked about is the culture that comes from within hasn't gone to a point where they're more incentivized to do certain things and more afraid not to do certain things because there will be penalties and there will be reimbursements, for example. So I think it gets more interesting as you talk through these, and I'm sure the audience here is also kind of getting a handle on how things should evolve in a more organic fashion, because on paper it looks very simple. Do good
Mhm.
for the patients, take care of them, you'll be incentivized to do that. Everything is good, don't do these things, they are not useful. Not, the goal should not be seeing more patients, rather
Yeah.
making more patients more healthier or manage their conditions well. I think
Common sense.
yeah, common sense, but I think what you're touching on is actually the crux of the whole value-based care. So
Mhm.
I'm waiting to learn more, actually.
Let's go ahead and go to the next slide. So these are just, I throw this up not to go over in detail, but there are various categories to how people get paid, right? They get either they just category one, they just get paid fee for service. I see you, Suman, I take care of you, you leave my office, you pay a bill, right? That's professional fees, right? Category two is fee for service with a little bit of sprinkling of quality and value, right? That's the MIPS program that we're familiar with here in the United States. Category three is taking that to a higher level, more than a sprinkling, alternative payment models on top of the fee for service architecture. So this is the Medicare Shared Saving, ACOs, and others, Comprehensive Primary Care Plus, and to have it for payments for procedures as well. And in category four is where you're really starting to take alternative payment models using population-based payments, bundle payments, things of that nature. And then you start thinking about global capitated budgets and how people get paid. So it moves from episodic to bundle payments, essentially, right? So Suman, I take care of you, pay based on your chronic disease. Let's just say they give me $10,000 a year to take care of you. Now, I need to make sure that I stay within the 10,000. I order things appropriately that makes sense. I keep you on the path to quality and make sure. And if I do that, anything that's left out of that 10K is the providers, right? Or the health systems. And so the only backside, the way I always think about this, so I've talked to a lot of providers about this. One thing you don't want to do is make sure that you're not penny pinching in order to keep the money and then not providing the care. This is why, again, it's still based on quality and outcome, right? If I'd said, Suman, I'll just see you once a year. Well, wait a minute, I used to be seen 4 times a year. No, I don't need to see you but once a year. I'm going to keep more of your money. That would fail, right? That would not help the patient in any way. So again, that's why there always has to be, with bundle payments, there has to be the value and quality equation as part of it. And if you look at the next
Yeah.
slide, it kind of shows you how, what percentage. You could see right here that that the true bundle payment piece is a very small percentage compared to fee for service in America, right? And you can see that everyone is tipping their toes into value-based care in some component, either through commercial or mostly MA programs. This is where health systems are starting to either do it themselves internally and start a MA program, partner with another payer, or they're staying mostly fee for service as part of this. Anything surprise you about this, or what do you see? What do you think about this this data?
This actually surprises me a lot on the column in the green, because I was hoping there would be more adoption towards population-based payments than fee for service. What it tells me is it hasn't progressed as fast as it should again, going back to the common sense approach we talked about, the adoption is very low, is what you're telling us. It's a very powerful slide, because what it also tells us is every time people look into their health, the penny pinching thing that you talked about, even if they're in the value-based care system, they may not want to do certain check or test that probably they would have done in a fee-for-service model. But since the value-based model kicks in, there are additional dollars for, let's say, an X-ray or some kind of testing that you would normally do, you would not. And how does it affect a member's health? I'm not saying it does, but if it does, who else, who gets responsible for that? So there are a lot of complexity around that, I would say.
Yeah, and the folks who've been on the call who've been following Medicare Advantage in America, it has its issues too. We're discovering that some of the promises for MA programs are not holding true. And so I think it's going to be a continuous learning process. I think that we can't wait for perfection in order to do this. It's going to be a continuous learning model. And I think we need to not only learn from folks here in the United States, but worldwide. Netherlands is, I think, really far advanced in some of this, and based on literature I've looked at. But it's going to have multiple versions of how this is going to work. And it may be even based on population, maybe based on region, maybe based on chronic disease as well. So we got a long way to go. Next slide. I think there's another poll question. So has your organization implemented value-based care in some shape or form?
Take as much as 30 seconds to answer this. Should be very simple in my mind, right? I mean, if you look around those options, it's very evident that people know about value-based care, but how have they implemented, in what form is the question. A few more seconds. I wish there was a music going on in the back and the TikTok sound.
The elevator music.
Yeah.
Or you could do the Jeopardy theme.
You could. Yeah. Next time we'll try that.
Yeah.
Okay. Almost there. All right. So looking at it, very few have said, as expected, they're fully implemented and successful. Again, it is, in my mind, it's an ongoing event. So if you think you have fully implemented, there will be always improvements that come your way that makes you 98% complete or 95% complete. But majority of them have said they have not started yet. I think 19 out of 53. Some are said just beginning. I think if you add those two numbers, it's more than 50% of the response that either they have just started or they haven't done that at all, right? Which is I think what the national average shows too. So if we go to the next slide, maybe that probably has some sort of a view of what the impact is, right? So if I were to look at this, right, the value-based care, it's a McKinsey study that came out, which talks about projected to reach 1 trillion in enterprise value from 500 billion. It's almost double the dollar impact. So a lot of money on the table, right? And then the lives impacted, right? Which is the most important thing personally to me, is when you look at people, approximately 160 million lives, almost half the population of the US is in value-based care today, with 15% growth. Now, what we mean by this is it's not entirely 160 million people doing everything end to end, but somehow they have been impacted or connected with value-based care, which is a huge number, right? And the growth, if you look at it, is 15%. It's not a small number. So some numbers to showcase here is the importance of value-based care and the impact of value-based care, right?
Yeah.
Going through the next one, Dr. Patel, I think you have probably a better perspective on this.
Yeah, it's interesting, that poll, and I'm looking at the participants, and I know we have a very diverse and international crowd here. But if you look at the United States, as you mentioned, about half the population is in some sort of value-based, risk-based program, right? Now, value-based, if you look at it from a tier perspective and a volume perspective, you can go from very little to very high, right? And there's varying degrees of that. And this map shows you the penetrance value-based and where some of the concentrated areas are as percentage of accountable care organization lives across the United States. You can see some bare areas in the Midwest. You could see that a lot of East Coast is really diving deep into value-based. My state of South Carolina, almost every health system here has a large group of value-based care patients. At my old organization, 1 in 3 were probably in some sort of value-based care program. And I think their goal was to get to 60, 70% by 2030. And I think you're going to continue to see that. And there's a lot that goes along with this, right? It's hard to layer value-based on top of a still predominant fee-for-service model, right? So, for example, when I practiced, I saw my patients. Some of them were part of a value-based, some of them were not. You don't know which ones are. You don't know who's attributable to a value-based care program or not. So we did scoring and quality measures on everyone, and that's what you should do. You shouldn't cherry pick your value base and okay, this is where we need to concentrate versus the fee for service. They all should focus on all of them, because at the end of the day, a larger portion is going to become part of a value-based care program. So you better start early now looking at quality and quality metrics and incentivizing your providers from a quality bonus perspective as well. So this goes all the way back down to, I used to do contracting for providers, incentivizing and building that as part of their compensation, right? So that they don't feel penalized as part of this. And one thing you always have to be careful about here is that you don't want to cherry pick all your healthy patients so you look good, and all the patients who are chronically ill, who have challenges in getting better. And this is where we need to make sure that we're not penalizing providers for spending more time with the complicated patients. We're also making sure that the provider is supported with social workers, care coordinators, and others. There is a new program, if you go to the next slide, actually that's very interesting, that just started actually this month. The initiative was started early June. I think it launches in July of 24, but it's called a Making Primary Care Model. And it is about 11-year, multi-year model that they're looking at, and is really meant to improve care management and care coordination and equip primary care providers with tools to form partnerships with healthcare specialists, leverage community-based connections to address patients' health needs. Now, if you look at independent practices, it is extremely hard to do value-based care right. And so this Making Care Primary model really is to have all the support structures in place to help independent practices be successful in reaching their goals and starting to get into value-based care. I can promise you that if that survey was taken by folks, I bet a lot of folks who are on that survey who answered, I haven't started yet or barely tipping my toe into it, are ones who are probably not involved in a large multi-billion-dollar health system. They're probably individual providers, maybe they're individual practices or small practices. And because this costs money, right? In order to change your whole model, how you get paid, how you take care of your patient, requires a good infrastructure. And one of that, a big part of that, is your electronic health system and data integrity, which we'll talk about. So the Making Primary Care model is starting across these states that you see on the screen. And like I said, it's about an 11-year, almost 10.5-year model project to see how they can put the resources in place for primary care across these areas.
Yeah, and Dr. Patel, I'm from state of California, and I'm looking at it, and there is no adoption. I know it's a month old, it's still catching up, but in the previous slide as well, I thought the adoption is kind of slow in the West Coast compared to the East.
Yeah, even
just an observation.
Yeah, even in the previous map, you can see that. Now, this is a special model, right? This is a whole new model, and they've deliberately only started it in these 8 states at this time.
Okay.
And so, unfortunately, politics do play a part, right? Which states on the screen are Republican versus Democrat, right?
I see.
And who's accepting certain Medicare dollars, who's not accepting Medicare funding and dollars, and so politics play a part in some of this. So I'll leave it at that.
Understood. Okay, makes sense. All right, time for a new quick poll. How much of the world data is generated by healthcare? Let's see if our audience knows the data piece of it. I mean, we talked about value-based care. We know it is important. Now, do we know how much healthcare data is generated on an overall basis? Like if you have 100, that's 100 terabytes worth of data overall. There is banking and financial services. There is, healthcare. There is manufacturing. All sorts of industries coming together. How much is the healthcare contribution to that data set is the question, right? Let's see if we guess it. I was thinking it was probably 20%, maybe sometimes 25%. I don't know. Some people have told me that it goes up to 60%. I don't know if it's true. We'll find out. I may be completely off. Okay, few more seconds. People are voting, I know. All right, so 15% have said 15%, 25%, so 25% have said 25%. I'm reading it. 30% have said 38%, have said 30%, and 23% have said 35%. Okay, so I think the right answer is 30%. So majority of them have said it right. And I think it's going to grow up until 36% by 2025. It's probably, one of those fast moving data creating industries that you cannot bypass or overlook, because in my mind, I've always said this, education and healthcare is here to stay, and it's going nowhere. But the pace at which the healthcare data is generated is going to surpass every other industry. And Gartner has predicted that, and there's a lot of study around it. So anyway, we switched back to data for a reason, because there are two parts to this story that we have started saying in the beginning. Is we understood what value-based care is, we understood what its importance, its impact areas and key focus areas, and how it kind of impacts general healthcare industry. But we're also going to talk about this data journey, right? You know the data is very disparate, it's all over the place. But if you were to oversimplify this, there are only 4 steps, right, that you want to pay attention to. One is identify your data sets, where they are, how siloed they are, how different they are from each other. Like I have seen health systems having claims data in multiple different formats and multiple different types. And every single time you look into data, there are 2 aspects that you want to be careful about. One is the completeness of the data and accuracy of the data. You may have a complete data, but not accurate. You may have accurate data, but not complete. And none of these situations pan out good for you unless you have both aspects of the data covered, which is completeness and accuracy. So identification of your data and making sure it is coming from a trustworthy source. Sometimes it is internal, sometimes it's external. Sometimes patients create their own data called PGHD, patient-generated health data. Whatever it is, got to identify them, and then basically making sure that they are complete and accurate. So that's one point. The second one is consolidation of data. So as you think about, and this is what I think majority of our health systems are taking help of, the big tech or even smaller organizations like us, GAVS and GS Lab, is how do you consolidate data and have a framework that can centralize all your disparate data sources, making sure it's either a lakehouse concept or traditional data warehouse concept, but you're storing the data, you're making sure it is connected data. It is not disparate data anymore. So the consolidation brings all aspects of a patient's journey into perspective. For example, if I'm a patient with type 2 diabetes, I go see a doctor in hospital X, then I go and travel somewhere, I see another doctor in hospital Y, and let's say he found out or she found out some condition that I didn't have. before, how do you know these data records are connected? How do you know if I'm getting the care I need? And how do you know if my health is optimal depending on where I see my doctors, or if I'm in network or out of network, or all of those nuances that come with data, right? So I think consolidation and making sure there is a view, we call it patient 360, there are multiple names at it, but how do you make sure the data is connected so you know at any point of time what's happening with a certain individual? So that's consolidation. Then the sharing aspect comes in, which is critical. And that's exactly what I was just giving an example of. If hospital X and hospital Y need to share information so that at the right time, let's say there is a procedure happening, we have all the information about the patients. And now, not everything, I think most of the electronic health record have kicked in sooner or later, but then still there are some disparate nuances around sharing of data. And people always talk about whose data is it? Is it a patient's data? Or is it a hospital's data? Or is it a doctor's data that the doctor is making sure that it is protected, right? So patient consent management kicks in. Consent management is something that everybody needs to pay attention to, because the consumerism of healthcare has begun. The patient is at the center of it. The patient decides what data needs to be shared and what cannot be shared. So if you're building something like a sharing mechanism to have interoperability kick in, or even generally sharing data, make sure the patient consent management system is built right, so the accurate permissions are captured from the patients or members, so that the sharing can happen seamlessly without further checks and balances when the time is of the essence, right? And last but not least is the governance aspects of it. So we talk about data in claims data or billing data. You have other kinds of data coming in and EHR data coming in. How do you make sure the data is at the center and everybody has a right set of governance in place? So it's not a discussion about you can have access to my data set or I don't need your data set. Rather, what is the true source of data and who has stewardship on those data elements, and whether, going back to the data completeness and accuracy, whether the data is complete and accurate, and what is the true source of truth for certain types of data. If you don't have that in your organization, you're going to have a difficult time, and most of the organizations do struggle even today about data governance and the policies around it, and who controls what aspects of information that can be critical to let's say data science activities, or making sense of data, reporting requirements, regulatory requirements, you name it, we have it, right? So that's pretty much a data journey that I think every organization ought to think, and they may be in the maturity level 3, they may be doing some sort of governance, maybe doing all 4, but not doing a comprehensive analysis, like I pointed out, could be an X factor for them to either do it successfully or just do it on a superficial manner just to check boxes, right? Because you ought to be doing it in a more structured fashion. So if you go to the next slide, I think these are critical data components in a value-based care. And Dr. Patel, I'm going to call you out to talk about a couple of those. There are a bunch of these, and these are, again, if you are in a healthcare organization, you must have dealt with one or many of these, at least to a point where the elements in this make sense towards not just the reimbursement, but the total health outcome of the patients. But Dr. Patel, any things you want to pick in particular and talk about briefly for the audience?
Yeah, just backtrack a little bit. I think the 30% number is going to grow exponentially as we start to think about all the other areas of data we're looking at. So historically, the data that is measured is what's in the electronic health system, right? Your chronic diseases, your medications, your social history, family history, those types of things. But as we evolve and more technology takes part, and there was a question around RPM. Yes, RPM is going to play a huge part in value-based care. That means that you're going to have, just like me and you right now, Suman, are generating data, right? Where heart rate, blood pressure, pulse ox, sugar, these things are going to be now measured almost near real time, and then looking at overall trends, and then making a intervention at a certain data point after you get enough data points, and making sure that the data points are real and accurate and not noise, right? You're not reacting to inaccurate data. So I think number one, healthcare data around Patient 360 is going to grow exponentially, because that's going to be much more data generated outside of the EHR, from wearables, from environmental to social determinant and other things. So I just want to make sure I said that. In regards to these components, a lot of people handle these things separately, but they're all related. Let's talk about ACC. So important as part of value-based care. And anyone who's looking into starting to look at value-based care, you better look at your ACCs and RAF scoring. And what does that mean? So if you had 10 patients, then a portion of them may be higher when it comes to chronic disease than others. So the way value-based care works and reimbursement is going to change is that you'll get paid more and reimbursed more if the risk score is higher. And the risk adjustment factor is based on your HCC coding scores, right? For example, Suman, let's just say if you're a diabetic and your A1C score 7, so that means you're doing extremely well and you don't have other issues, right? You're not having vision loss, you haven't had a stroke, you don't have a stent, your kidneys are working well, and you haven't had any limbs cut off of you. But let's say another person who has diabetes as well has chronic kidney disease. Maybe that person has had a stroke. Well, that's not, as you would code, a uncomplicated diabetic. That is a diabetic with complications. That is a diabetic with nephropathy. That is a diabetic with peripheral vascular disease. So when you put those in, your RAF score starts to tick up. And I think the RAF score is the heart of a lot of things that we need to be looking at moving forward. It can help us not only from a reimbursement perspective, but I like to use it for load balancing schedules, right? Let's not have multiple complicated patients back to back to back for 15 minutes each, because you know it's not going to take 15 minutes, it's going to take 30 minutes, 40 minutes with each patient. So that causes a trickle event that the next patients are going to wait longer and longer and longer, right? How about if you had them assigned as red, yellow, green? How about a red and then a green and a yellow and then a red again? Load balance. Maybe also shows that if one provider has 2,000 patients on their panel and they're mostly green, maybe they can see 3,000 people. If most of them are red, maybe they should be seeing 1,000. They should be spending more time with those patients and not, penalized for seeing less patients because they're dealing with high RAF score, high risk patients. So those two extremely, extremely important. HEDIS measures is also very complicated. They're like 90 measures over like 6 domains. Effectiveness of care, access, availability to care, experience, utilization, health plan components, and then reporting coming out of your EHR. So there are various, and if you just Google HEDIS, it'll show you all the different components and subgroups within that. I think social determinant is extremely important. You need to know your patients. What are the challenges? Transportation. Do they have broadband? Do they have internet? Do they have a cell phone, a smartphone? How those things will help determine how you're going to engage with that person. So the interesting piece, what I like about these data components are the same components that I use as previously as Chief Digital Officer, and I now tell my clients is that you want to try to use this also when it comes to your consumer engagement, right? This is how you should, that data should be how you should actually, when you look at putting your consumer engagement strategy together, you need to be using this data. You don't want to have disparate data coming from your CRM, your EHR, and your financial data. You want one conduit for this data, and it needs to be able to then apply automation and AI tools that will drive people to the right avenue of care based on their data. Right now, we treat everybody the same, and it shouldn't be that way. Length of stay is very important. 30-day readmission rates. We look at these because health systems cap certain DRGs to certain payments. You get admitted for community-acquired pneumonia, or COPD. There's a certain DRG for a certain length of stay, and if you stay beyond that, well, we're not paying for it. But how about if that person goes home with COPD and comes back in 30 days, and you're not going to get paid for that either, right? So again, understanding that risk adjustment factor and how that can put, sway a person when it comes to length of stay. And this is a huge conversation that's happening across the country is around big data and centralization of function, like in a command center as air traffic control of movement people in hospital, post-acute and ambulatory. So there's a lot we can dive deep into each one of these components, but what I want the group to understand is don't look at them as individual data points. But they are all linked in some way, and there's a lot of overlap. And the last thing I would say is just remember your patient is not a data point, right? Look at your patient holistically and beyond just looking at them as a blip on your screen is another piece. But I can dive deep
Yeah.
into any particular ones that you want me to here, Suman.
No, I think you kind of hit the nail on the head, right? A few things that you said was very important on HCC and RAF. And like you said, everything is connected. It's just not one data point or one particular dimension that you got to look at. You got to take a look at a holistic view of it. That's why the value-based care is so important. They just don't look at one aspect. They look at everything else too, right? One of the examples, and when I was in Kaiser, I was doing this, and then now I do this for our clients, is talk about social determinants of health. So SDOH is something so critical in a very simple term. If you want to explain people, I do this in 20 seconds is your doctor doesn't know when you lost your job. When you lose your job in a lower income group, food insecurity takes over. That means food becomes number one priority, medicine becomes secondary. So the med adherence, which is a dominant factor in Medicare, or you can even talk about Part A and Part B and Part C, all of that.
Yeah, it's part of
So the social determinants of health plays a critical role, which your doctor most likely will be unaware of. If somebody loses their job, they lose the insurance most likely, and they're going to fall behind. They're going to be the people who will have medication non-adherence, and that is a big impact to their health. And it is predominantly unknown unless you find out those factors and connect that with the patient record. So there could be programs that could be launched to make sure those patients are taken care of, especially people who are chronic conditions, right? So there's just one aspect or dimension how actions can be taken by looking at it. The other one is the HCC. Dr. Patel, you talked about it. I think if some people are diabetic and they are taking insulin, but the coding issues don't catch that, and or HCC codes were wrongly kind of interpreted or calculated, there could be a lot of issues in terms of reimbursements, in terms of taking care of the patients and making sure they're marked as the chronic patients. So there's that coming into play. So a lot of things are system driven. A lot of things are actually visible to the providers. Some are not visible to the providers, like the social determinant of health example I gave, which brings me to the final slide, which you can go to, is how do we design a system? And this is again an attempt. It's a reference architecture. If you go to the next slide, that talks about your left, which is your disparate data sources like claims, your Internet of Medical Things, EHR, imaging, social determinants of health, all about how the patient is either generating data or interacting with health systems, or even has his or her own individual social behavioral setting that you're getting the information from. And then how are you building a data management framework? This is again a reference architecture, but if you open it up, it basically talks about multiple things. Now, not all pieces are applicable to all health systems, but if you look at it, data lake, we talked about data mining, looking to data quality and accuracy, data cataloging, understanding what kind of data is what. These are all pieces of a data management framework that we help our clients build. The best part is the data governance, which is built around it so that it is not siloed. It is looked at the same way by every single business unit. For example, claims and then the health plan aspects of it kicks in the same way as the provider aspect kicks in. So they look at the same set of data, they interpret the data in the same way. And then if you look in your right, basically you have patient, CMS, and other entities that are the recipients of data. They have their own requirements. And I talked about patient consent management. You can have other kind of restrictions on how the data can be extracted, how the data can be mined for them to basically CMS's regulatory agency. So they need certain types of data in a certain format. The patient may say, I want to look at my chart and look at how am I doing today versus yesterday. And there was a question about that, I think, from someone saying how RPM plays a critical part in value-based care. Well, that's exactly what the patient would want to know. Am I healthy? Am I being kept healthy? Or should my doctor be doing something else than what I'm doing right now? Or should I be walking less, running more, or eating less of this, more of that? Those are things now becoming a table stakes in healthcare industry. So that's probably where a lot of recipients of data come in, and then they play a critical role there. So again, this is an attempt to show you what kind of disparate sources are there, what kind of recipients of data are there on your right, and how the data management framework can be built in a systematic but organized fashion with data governance in mind, so that they're never out of the loop, they're never siloed, and they're always connected with focus on quality, accuracy, and completeness, right? So that pretty much sums it up for our conversation today. You can ask questions later on through LinkedIn. These are our codes. You can ask us. We'll be happy to answer your questions. I think we got some questions that we'll try to answer. We have 4 minutes, and then we'll see what can we do. So let me read this. Dr. Patel would appreciate if you could respond to these, and I'll chime in as well. So the first question is, what are the typical challenges both at the business level and at the technology level you face when implementing value-based care?
Yeah, at the business level, number one is building that culture we talked about, right? Changing your payment models, your contracts for your providers, and really having them really be incentivized to move towards more value. And so that's always been a challenge, because at one side we're dinging them if you're not seeing enough patients and your overall base salary goes down, versus you're giving better care, better output, and better outcomes, and we're not giving them a bonus, right? So I think there has to be a bonus on top of this incentive pay model, and then on top of that, if I work extra hard and make sure the person doesn't go to the emergency room, but I have to spend an hour with them, but I saved the ER visit, we should capture that. We need to be able to capture when these sort of great things happen and not hold them and penalize providers. From a technology perspective, there's lots of challenges. One of them is the fact that we don't have clean data, inaccurate data, disparate data, data from different areas. In order for value-based care to work, we need to have data portability from one place to the other. If someone goes from one hospital to the other, yet he's my patient as a primary care and he's under my value-based care program, well, I need to know what's going on at the other places. So, and they need to know what I did. If I ordered already a CT of his head, they don't need to order another one. Or if I order these labs, they don't need to order another lab and repeat everything like they do by protocol, right? They need to be able to have access, easy access. So technology, I think we need to look at cleaning the data. I think centralizing it, putting it to a centralized data lake, ETL, visualization, normalization, and then applying, AI and other nice advanced tools on top of it that can add automation and do a lot of tasks behind the scenes. Because with this level of data, we cannot throw people at every single data point. We need to have the ability to do a lot of work behind the scenes and automate as much as we can.
Yeah, very well said, Dr. Patel. If I may add one point there is, when we have business users and analysts looking at data, we need experts looking at data. So the self-service becomes a priority. Most of the time they complain that the technology team hasn't given them the data sets they need to mine and operate on. So I think that also becomes a critical component when you're analyzing your data. Make it available for the end user so they can slice and dice. So it's a democratization of data, as we call it, but the analytics piece kicks in there. Some are self-service, some are built for executives to look and take action on. Launch plans can become possible through that. So lots of areas to cover there, but I think that's where a lot of challenges come too, because they're not available, or the technology team wants to keep it more secure, and they're worried about the members' data loss and things like that. So that's another area to talk.
Suman, there's one question about RPM. I know we got just less than a minute, but just
Yeah.
really quickly, is remote patient monitoring should be part of your value base. You should be aligned with the programs that you're doing risk on, diabetes, hypertension, et cetera. And so blood pressure cuffs, glucometer, CGM devices, weight scales, CHF, and others. Align your RPM with the risk you're taking as part of value base.
And last question I'll take is, should organizations look at in-house data management options or work with third parties for value-based care? I would always say, first take a look at your data set, look at your organization culture and goals and objectives, define that, and have some kind of an assessment done before you jump into implement value-based care, because every organization is different, their priorities are different, and the technology implementation could be very unique to your situation. I think that can only be achieved by doing a thorough analysis of where your incentives are, what your priorities are, and what your organizational goals are, and then more importantly, where the data is in terms of maturity, completeness, and accuracy. So with
Yeah, I
that,
think the key is maturity
go
for
ahead.
sure. If you're not
Yep.
mature to move forward, it's okay to ask for help. And because your IT department is doing more than just this one thing. So I find that the rate limiting step sometimes is the lack of personnel and know-how to do it. And this is where partnering with a third party like GAVS would be probably the best thing to move forward and accelerate your value-based care program.
Great call out, Dr. Patel. Well, thank you, everyone. Really appreciate you joining the call today. And we'll look forward to more questions in our LinkedIn and stay in touch for future webinars. Thank you, everyone. Bye.